Here, what we're looking at is that there are two publications. The first came out in Gastroenterology, and the second came out of Johns Hopkins in the Journal of the Academy of Nutrition and Dietetics about microbial dysbiosis and IBS. And I use this particular illustration from the prior publication in Gastroenterology to show that when you look at individuals with IBS, they tend to be deficient in certain commensal bacterium, such as bifidobacterium. And also there are certain bacteria, particularly Enterobacteriaceae, and pathogens that are more common in IBS. So we know that there is an imbalance of the bacteria in IBS. And this imbalance is important because basically what we see here, and this is a nice integrative composite model for the pathophysiology of IBS, is that we have a microbial dysbiosis shown down here, which is a dysregulation of the community of commensals with the pathogens, and such that they're causing a hyperpermeability. The microbial peptides then, by permeability, then amplify the immune response, which is more pro-inflammatory. This will then find its way into the brain and cause a gut-brain axis dysregulation. Also, the permeability will allow the inflammatory byproducts to also cause hypersensitivity, dysmotility, and this all turns into a vicious cycle. This particular slide may be very helpful to study and or to understand how we can approach this from a natural medicine point of view. This gives you more of a visual, is less complicated. This shows the microbial imbalance and some of the approaches that I had mentioned, such as probiotics, rifaximin, which is a short-term measure to get SIBO or small bowel overgrowth under control. There is really no data on, or there's no control data on fecal microbial transplant for this condition. It's experimental. But these type of therapies at this point in terms of rebalancing the gut microbiome may in fact be very helpful for changing sensitivity, for changing motility, and improving the permeability state, and ultimately helping us to reset the gut-brain axis. So antibiotics, they can be friends or foes. We know that broad spectrum antibiotics in particular can be foes because they not only deplete the commensals, but they increase luminal proteases, which can actually reach the mucosal barrier and cause immune activation, and also create a situation of hypersensitivity by breaking down the mucosal barrier, enhancing inflammation, and also affecting the nerve function. So we know antibiotics such as this individual may actually increase the risk of IBS-D that this individual has. So what about the therapies? The therapies for IBS, at least we know the over-the-counters include the bulking agents and laxatives and antispasmodics and antidiarrheals and anti-gas, but what about from a more targeted natural medicine point of view? What are the strategies? Well, we can talk about stress reductions, but we really don't have the time, but they do work. What we can do in our world of nutritional medicine is talk about how we can target the microbiome, how we can use medical foods, herbals, nutraceuticals, and enzymes to improve the outcomes of IBS. So what about probiotics? Well, as you probably know, in the last few years, that there's some data that came out both out of the Weizmann Institute in Israel and also a large negative trial out of New England for infantile gastroenteritis, which casted doubt on the efficacy of probiotics for a number of conditions. And obviously this has been popularized in the media to really cast doubt, if not provide some, let's say, some narrative that probiotics are snake oil, but we do know better. And we know that there is meta-analysis, there's guidelines, that combination probiotics can actually, by Alexander Ford and other colleagues, in a meta-analysis in what we call the Red Journal or the American Journal of Gastroenterology, showed that combination probiotics may reduce persistent symptoms, improve global symptoms, uh, produce improvements in pain and flatulence, and also can improve bloating, which is a very difficult symptom to treat with IBS. We know that there is a relationship of SIBO, or small intestinal bacterial overgrowth, to IBS. And this, again, this is from Alexander Ford and other colleagues that looked at SIBO in IBS. And as you can see here, the Poole-Dodge ratio is that there is a 3 to 5 times higher risk of having SIBO in individuals with IBS. So odds are that about 60% of individuals with IBS have an element of SIBO, or small intestinal bacterial overgrowth, again highlighting that the majority of these patients have an underlying dysbiosis that is present and treatable. So what is SIBO? We know small bowel overgrowth occurs. It's more than 10,000 microbes per mil of fluid in the small intestine, and the underlying causes are many. Medications such as the proton pump inhibitors, which really wipe out gastric acid, hypochlorhydria, underlying enzyme deficiencies occur, anatomical disturbances, surgical therapies, ileocecal valve issues, thyroid conditions, which can slow the gut, and also motility conditions as well. These are all potential, and others that can cause SIBO, with many associations with SIBO. Allison Seibecker is one of a naturopath out in the Oregon area who has a really comprehensive website on SIBO, and talks about the different underlying conditions and updates them almost on an annual basis on her website. Also, Neera Jacoby out in the Australia, New Zealand area, likewise has a good website and has educational programming on SIBO. But in any event, what are the treatment options for SIBO? Diet. We have ample evidence showing a low FODMAPs diet may be helpful. Again, the weeding of antibiotics is short-term with rifaximin, but we can also accomplish the weeding with different herbs that we will talk about. And we have one particular study out of Hopkins that is widely cited and used by many in the natural medicine world. Probiotics has multiple mechanisms to be helpful. Serum-derived bovine immunoglobulins can be helpful. Enzymes and other types of therapies are out there. Stress reduction therapies, there are so many that have been studied and shown to be effective for this condition. Mind-body stress reduction in particular has been helpful. Acupuncture has been shown in several studies to be helpful. And we will talk about some of those. But at the end of the day, what we're looking to do is rebalance the autonomic nervous system and the enteric nervous system, and try to really calm the person and actually reduce stress, which can have a profound effect on IBS. So there's actual even meta-analyses on meditation, hypnotherapy. There's a form of hypnotherapy that's got directed hypnotherapy, for which there are meta-analyses showing therapy outcomes that are effective. Cognitive behavioral therapy, again, has many studies, such psychological-based therapies, and a combination of these in a multi-component therapies. All of these have been shown to be effective. Jost Langhorst out of Germany has written systematic reviews on this for your reference. So what about food? My good friend and colleague, William Che out of University of Michigan, has been one of the leaders in popularizing the concept of food as medicine for IBS. And what we do know is that food can be a provocative factor in the vast majority of patients with IBS within 3 hours after eating. So we know food can be a culprit, but if we can target the elimination diet strategy, food can be a friend in terms of improving the outcome of IBS. So we know that there's a number of different exclusion-based therapies on the market. We know that there has been IgG4 directed therapies, ALCAT-directed therapies that have been published, although there's one study on ALCAT and there's several studies on IgG4. Elimination diets have also looked at the top 8 food allergens as mechanisms for elimination diets. We will talk about the FODMAPs, or the fructo-oligo-di mono and polyols. That's what the FODMAP stands for. These are highly fermentable foods that are, let's say, not well transported through the gut and can actually cause a number of GI symptoms. Gluten is in this family, lactose is in this family, fructose is in this FODMAP family, and elimination diets that also include restricting carbs can also work as well. We know that there are food additives that are also culprits for IBS and also IBD, which is a different topic. Caffeine can also disrupt motility, particularly those with diarrhea predominant disease. And we can talk about different elimination diets, but realize when people have weight loss, we have to be very careful on how we restrict people. And this should be done under the guise of a medical professional, not necessarily an MD or a doctor, but this could be through a dietitian, health coach, naturopath, so on and so forth. It should be under some guided counseling. Dr. Singh, Radeep Singh, and I published this in the GI Clinics of North America, a systematic review, which shows you the different therapies and diet and what the levels of evidence are, and basically the quality and strength of the evidence using targeted elimination diets, IgG4 testing, generalized elimination diets not having the best outcomes, or let's say the levels of evidence, but the FODMAPs certainly probably have the highest level of evidence out there. And we'll review some of that for today. So gluten has been one of the oldest and most popular forms of eliminations. And you can see with these FODMAPs in the middle, you can see how wheat and gluten can have a number of different ways by which it can cause IBS. It can also, we know that individuals who have gluten intolerance and celiac also can have permeability issues, which is another feature with this IBS type of pathophysiology, with mast cell degranulation, pro-inflammatory cytokines, and also IgE and IgG4 release. But the FODMAPs also include foods such as garlic, avocado, which is rich in xylitol, and also honey, which is high in fructose, and obviously milk, which is high in lactose. And these can actually cause a rapid fermentation and gas production, and also fluid sequestration into the gut. And these ultimately can cause the symptoms that we see with IBS. These slides may be very difficult to see. We'll provide you a PDF, once we're finished with the lecture, so you can see these a little bit better. But you can see that these are meta-analyses of the low FODMAP diet. And basically, you can see that there is improvement in abdominal pain, improvement for overall symptom severity, and also improvement in quality of life. So these are key metrics by which the low FODMAP diet can improve symptoms in individuals just with diet alone. And so it used to be kind of 20 years ago laughed at in the IBS field. and even in an IBD field, and people were told they can eat what they want, but they need just to take their medications, or it was all in their head. Now we're looking at a food first therapy for IBS, which is really, really game changing. Now, this is coming out of Europe. And what Dr. Bond and colleagues did was they actually gave individuals, or they put people on the traditional diet, or the traditional dietary advice of using the UK guidelines for IBS. And using the UK guidelines for IBS, they found that people improved as well as the low FODMAP diet if they followed these British guidelines. So we know that the low FODMAP diet works, but there is other ways to approach this as well that eliminate many of these high FODMAP foods. And this is just one approach out of the UK showing that using the British guidelines called NICE, or the NICE guidelines, actually worked out quite nicely, no pun intended. So some of the controversial features that you'll hear in the IBS world is that it has short-term effects. There is a high level of restriction, but it's something not to be on lifelong. There is a slow reintroduction phase that you try to eliminate foods over a 4 to 6 week period of time, and then you slowly reintroduce foods one at a time over several weeks. And people can lose weight with the diet, and that may be risky for people who already have a severe weight loss, particularly with the diarrhea predominant disease, where people tend to lose weight. You can see actually changes in the microbiome, but you can also lower bifidobacterium because you may decrease the fiber content, and therefore the friendly bacteria are fed by fiber or or soluble fibers, and you can see a lower of bifidobacterium. With this, people can improve with different types of diets, such as gluten-free, or the diet by Bond and colleagues that was based on the British NICE guidelines. So, so basically, yes. So just keep that in mind about the low FODMAP diet. You will see some controversy about it. So what are some of the things that you should keep in your toolbox? Are the anti-anxiety herbs such as the limonene, chamomile, and others. Antimicrobials we'll talk about for short-term treatment of SIBO as an alternative to rifaximin. Artichoke leaf extract has been shown to be useful for IBS. Elimination diets, fiber, enzymes we'll talk about. We talked about FODMAPs. Melatonin actually has been shown in 3 studies to be helpful for IBS, likely by helping with restorative sleep. But melatonin also helps to reset a hypothalamic pituitary axis. Peppermint oil has been shown in meta-analyses, including one from here at Johns Hopkins, to be effective for IBS. Probiotics. Turmeric may be useful for the diarrhea predominant inflammatory subtype of IBS. L-glutamine in terms of healing the permeability or the barrier breach, and zinc L-carnosine again may help repair the leaky gut that occurs in a subset of people with IBS. So again, the overview of the pathophysiology. In the middle, I place how the mast cell is hyperreactive, elaborates tryptase, and this and its byproducts can actually not only hypersensitize the nerve, but break down the gut barrier, allow that these food particles and microbiotic particles may get into the system and drive inflammatory reactions, but also realize that the microbiome interacts with bile acids. And somebody like this individual who had a cholecystectomy may have an alteration of the bile acid pool, and this may contribute towards the dysbiosis that occurs. So let's talk about the lab assessment of this individual. We note that her TSH is high, so therefore she may have an underlying hypothyroidism, which can actually cause gut motility issues. A low fecal elastase indicates pancreatic insufficiency, And in individuals with low pancreatic elastase, they may be more susceptible to small bowel overgrowth. She was found to have gastroparesis, which may also be a setup for small bowel overgrowth. She does have some autoimmune markers that are high. She was found to have dysbiosis on her stool test. She has SIBO. She also had fungal overgrowth and found to have B. hominis, which is a parasite, which individuals who are symptomatic with B. hominis would be treated. So realize that our functional assessment of an individual has found many different opportunities for treatment. So what about pancreatic elastase? Let me just, let me just give you some insight. Is that we normally, our sweet spot for pancreatic elastase is about 350 or so. In terms of our measurements, we even in the States can measure this with common laboratories. Years ago, you could only find this in a specialized stool study by a laboratory such as Genova or Great Plains or Doctor's Data. But now we can get it from LabCorp, Quest, or even a hospital laboratory. So once we start to see between 200 and 350, we start to think there's a decline in function. And so when somebody is less than 200, then we think about they need therapy like this individual. Pancreatic exocrine insufficiency can cause a number of symptoms such as steatorrhea or malabsorption of fat. This can cause stools to be floaty, oil droplets in the stool, abdominal pain, and actually weight loss from malabsorption, and can be seen in a number of different conditions, but also realize that this person also had gallbladder dysfunction, and therefore there is a correlation. This is a slide that was from a publication in Global Advances in Health and Medicine in 2014. And what it shows quite nicely is that there is a 7% or so prevalence of pancreatic insufficiency in individuals with diarrhea predominant IBS that is not seen in non-diarrhea controls, and also in individuals with chronic diarrhea. So we're finding that, as you can see, the fecal elastase is relatively low compared to those who are, let's say, more controls with diarrhea. So we know we should look for fecal elastase in individuals with particularly diarrhea predominant IBS. And so what happens is that once we give people enzyme therapy, shown here, is that the number of stools will actually decrease from, let's say, 6 per day down to 2 per day, just with enzyme therapy alone. So what type of enzymes products are available for individuals with IBS? Well, there's different enzymes that are different pancreatic based. Also for dairy, there's lactose or lactase based. There's gluten enzymes, lipase loaded enzymes, amylase loaded enzymes, and proteases, and of course combinations thereof. These are just slides that are more for you to refer to later on. This talks about aspergillus-derived enzymes, vegetable derived enzymes. And at the end of the day, you want to have a combination of amylase, protease, lactase, and also lipase that will help digest fats for individuals with IBS. We know that the individuals with IBS tend to have lactose intolerance, fructose intolerance. In the US. Let's say we are able to tolerate about 50 grams a day of fructose. The average American diet has 100 grams of fructose, and this is all determined by transporters, which are under genetic control, but also vary with age. And sucrose, which is a combination of glucose and fructose, also can have sucrase insufficiencies that can be either congenital or adult onset with certain SNPs that are variants. Something we don't talk enough about is the fact that a lot of the IBS patients have a histamine intolerance. And this could be either due to, let's say, a methylation defect that we see over time. And many of you likely test for methylation defects with SNPs. But what you can do in terms of a therapeutic trial is give individuals diamine oxidase with their meals. And this diamine oxidase can help degrade the histamine and actually improve histamine tolerance to foods. So this is one type of therapy to consider with individuals who you know historically have a problem with histamine or histamine-rich foods, is to consider a trial of diamine oxidase enzyme, which is available on the market. So we know that wheat can be a product and also wheat can be a problem because wheat has antitrypsin inhibitors, wheat is rich in gluten, wheat is a FODMAP, and the way the food or the wheat is processed, it has certain additives and preservatives which vary by country. So we know wheat can be a problem and something to think about restricting or eliminating in individuals with IBS, because a lot of people will improve on a gluten and or wheat restricted diet. We know that there is an overlap in individuals with IBS. We screen for celiac disease, but a lot of people have this non-celiac gluten sensitivity, and therefore, besides diet, we may also think about these enzymes that are gluten degrading in individuals with IBS who have gluten intolerance. This shows you the graph showing that she had SIBO. What happens is that we do a baseline measurement with hydrogen and methane. And basically, if you have more than 10 parts per million at baseline, you're highly suspicious for having SIBO. And if you rise by 20 parts per million over baseline within 90 minutes, it's evidence of SIBO. And you can see in this individual, they had a double peak in the small bowel and in the colon. So SIBO is something, again, we see in 60% of people with IBS, and certainly they may benefit by a low FODMAPs type of approach. So we have a polling question. Denise, not sure how you want to run this, maybe through the chat. Is that we want to do is have, how would you treat this individual at this point? Would you treat her with rifaximin for 10 days for her SIBO? Would you give Cipro and Flagyl? Would you give rifaximin and neomycin? Or would you give horse chestnut and oregano oil for 2 weeks? So I can't vote, so please vote. So how would you treat, and we're talking about her SIBO, would you do rifaximin, ciproflagyl, neomycin and rifaximin, or horse chestnut and oregano oil for 2 weeks? So how are we looking, Denise, at the poll?
Yeah, there's a few coming in. We'll give maybe a few more seconds for people to think.
And you know, this poll kind of it kind of gives us an idea of what you all do out in your part of the world, and I can talk about the data and what we do in practice. So we just want to be able to see what you all think at this time of night after dinner.
Okay, well, I think
let's take a look.
Let's see.
How are we looking?
Share results.
Okay. So this is great. So what I'm going to do is let's keep this up, and I'm going to walk through each option with you. So what we would probably do is one of two things. One, if insurance would cover it, and insurance is stingy out here with rifaximin, but one of the FDA approved indications for rifaximin is diarrhea predominant IBS. So in this lady with diarrhea predominant IBS, rifaximin at 550 BID for 10 days would be the approved indication. There is a large trial called Target 1, Target 2 trial led by Mark Pimentel and other colleagues, published in New England Journal, showing that this actually works over placebo for diarrhea predominant IBS. Cipro and Flagyl used to be the treatment for this, but it's as you all have indicated, has been unsatisfactory. And Cipro can cause tendinitis and cause actually rupture of the Achilles tendon, so it's something not to be taken lightly. Now, the neomycin addition is for methane predominant disease. So you wisely did not choose this option. If I had shown methane, then this would have been the best choice. Likewise, the horse chestnut is also something that is used for methane predominant disease. So very good.
So we did well.
Yes, you did. You passed. All righty. I show you the Blastocyst hominis because that out here it's been controversial whether you treat it or not. But if you have symptoms, you do treat it. You treat it with Flagyl. Herbs we haven't been found to be, highly satisfactory. There is different herbal preparations out there, but we just go ahead and use Flagyl or other antiparasitics. But this is from Genova Labs. Patrick Hanaway provided this slide a long time ago when we used to lecture at IFM together. And so when he was medical director at Genova, and they used to look at the stool specimens for the IBS patients, he found that, up to a quarter of people tested positive for a parasite. So that's why we look at these parasites in people with diarrhea predominant disease, because you can find it, you can treat it, and people can get better. So think about it. And also, I mean, when people get their stool sent to a very specialized laboratory, they're likely to be sicker and likely to have microbiome abnormalities. So it's a little bit of a selection bias, but keep parasites in mind when you see these people. So the summary of findings in this particular case included that she had gastroparesis and underlying dysmotility. She had multiple areas of dysbiosis, hypothyroidism likely contributing to a gut motility disorder, abnormal pancreatic function, which set her up for likely for dysbiosis, mast cell activation, even if it's secondary, is something to consider. And post-cholecystectomy diarrhea is a well-known entity out here in the States, and is treated with either bile acid sequestrants, or we can convert primary to secondary bile acids with probiotics. So how do we restore order to the gut, or order and balance to the gut in a very chaotic environment? We can follow the 5 R's of functional medicine. We can remove, replace, repair, re-inoculate, and thus rebalance. So this is just showing you data that we know that the higher the levels of primary bile acids, the higher the level of abdominal pain in these patients. So what we find in IBS is that there is a failure to convert primary to secondary bile acids. And as you can see, the primary bile acids will cause more pain. So either we can bind the primary bile acids, or we can convert them to secondary bile acids with pre and probiotics. So we know that, again, this is just a slide for you to refer to about what the motility is controlled by the enteric nervous system, the gut-brain axis as well. And we can see a variety of motility problems that occur in IBS that we can actually consider through acupuncture, meditation, natural medicine to help control motility. So for this young lady, we may consider iberogast, which was developed out in Germany, which is adaptogenic, or ginger root, which helps promote flow with gastroparesis, D-limonene, which is anti-anxiety, and also iberogast has some D-limonene in it, as well as chamomile to help calm the gut, calm the mind. Chinese herbs, TJ43 has been used to treat IBS. Acupuncture, acupressure, also to harmonize the HPA axis, visceral hypersensitivity, motility, inflammation. Acupuncture has a number of ways by which it can benefit individuals. And then again, we're looking at dysbiosis, a lot of ways by which we can actually have dysbiosis. Dysbiosis alters permeability. Permeability, again, will allow food antigens to develop, intolerance to develop, and also inflammation. And this becomes broadcasted systemically. Here's our treatment plan. Acupuncture, ginger to help promote stomach proper motility, and this will diminish the chances of recurrent SIBO. Low FODMAP diet, also looking at high histamine foods. High histamine foods, you can look at, particularly ferments are high in histamine. Herbs for dysbiosis, glutamine for gut repair, as well as zinc L-carnosine, pancreatic enzyme replacement. Check her thyroid, because oftentimes in individuals, even with ANA positivity, they can improve once you eliminate gluten and restore permeability. People can actually improve their thyroid function. Bile acid binders or probiotics to help convert primary to secondary the bile acids, and she did improve. So at this point, I'm going to stop sharing my slides, and we can get into the Q&A portion of our presentation today. Thank you.